All right, everybody. I am Jordan Hassel,
I'm Devon Bird.
and we did our spinal interventions on Chiari malformations. So real quick, we're gonna do kind of a refresher on what Chiari malformations are. So this is a translation of the brainstem and the cerebellum inferiorly through the foramen magnum. And so for this condition, there are 4 different types, each with varying degrees of displacement. So type 1 is the most common, and as you progress to around type 3 and type 4, the prognosis becomes more severe, and typically with type 4, the patient does not survive. And so this is caused by a disruption in the structure of the brain and the skull that typically occurs during fetal development. However, it can also occur after birth, but that is extremely rare, and it can also occur secondary to underlying health conditions such as spina bifida. So, for the first impairment that we highlighted that you may see with a patient who has Chiari malformations, we chose limited cervical range of motion. And so for the max protection phase, we chose for our interventions to be passive range of motion for the neck and shoulder movements. And so in particular, we would focus on cervical flexion and extension, cervical lateral flexion, and cervical rotation. And so these exercises could help maintain mobility, but they will also minimize strain, and they also give the physical therapist just a good idea of the patient's current range of motion when they come into the clinic. Secondly, we also said we would do chin tucks, and as Jess and Tavian discussed earlier, this can help engage the deep cervical flexors, the deep cervical muscles for stability, such as the rectus capitis and lateralis, and the longus coli. And so for the mod protection phase, we chose thoracic mobility drills. We chose this because the thoracic spine and doing specific exercises like with that can help improve the overall posture in the patient and reduce any compensatory movements. And then for the minimal protection phase, we chose specific dynamic stretches and then functional neck movements. So for the functional neck movements, we could do neck circles, but we could also do, as Dr. Carter was showing earlier, specific resisted diagonal movements. And then the dynamic stretches, we're going to show wall angels for one, so that way we can target the upper cervical and the shoulder muscles as well. So I'm going to start by demonstrating that. So for the max phase, I'm going to have Lexi come and sit down. So to start, we're just going to simply move through some passive range of motion. So first, I'm just going to move her through flexion. Okay. We move back to cervical extension. We also said we would want to analyze and see how they do with cervical rotation. And then a lateral or side bending. Perfect. And then for the other one that we chose for the max protection phase, we did chin tucks, and we specifically said we would do it in supine. You can do it supine or seated, but I'm going to get you over here at this table. And so once again for this one, I'm going to instruct my patient to try and bring their chin in without activating too much of their neck muscles. We're really trying to focus on those deep cervical muscles. So I'll get you to try to bring your chin into your chest just a little bit for me. Perfect. How she's doing that, we're not trying to lift the head up from the pillow or really flex the neck too much. So I'd have her hold that for a couple seconds and then go back to a neutral position. And then for this, we could have the patient do it around 10 reps, about 3 times. And so that's good. And then for the mod protection, we specifically said we would do thoracic mobility drills. And so the one that we focused on was going to be seated cat-cow. So I'm going to get you to sit up on the edge of this mat for me. Okay. And I'm actually going to show you and instruct you by showing you. So for this one, you're gonna start by going into what would be the cat position. So you're gonna kind of roll your shoulders forward and slouch your back, kind of like you're a cat getting ready to jump. Perfect. You'd hold this for a couple seconds, and then you're slowly gonna come back up, roll those shoulders back, bring your chest up nice and tall, get good posture, hold that for a couple seconds, and then you would go back to the original starting position. And so for this, we could have our patient do this once again around 10 times. We'd have them do 3 sets of this and see how they do with that. And then moving into the minimal protection phase, we said we would have our patient do functional neck movements. So to start with, I'm going to have you do just some simple neck circles. So you're just going to slowly be rotating your neck. Once you get to the starting position, you can slowly rotate the other way. Good. And this is going to be able to help the specific patient when they return back to normal function, as we saw earlier, to be able to do some of the diagonal movements. However, we're going to specifically target the diagonal movements the same way that Dr. Carter was just a second ago. So, alright. Let's see, I'm going to put this over your head real quick. Right here. Perfect. I'm going to get some resistance, and I'm going to have you try to look diagonally towards Seth. Good. All right, you'd hold that for a couple seconds, and then you go back to neutral. Good, and we can do this a handful of times, and then we could also do other way this time. Perfect. Okay. And then for our dynamic stretches that we highlighted, we would specifically for this one do what's called wall angels. So for this, Lexi, I'm going to get you over here and I'm going to shut this door so we don't have a wall to use. So to start with, I'd have you up against the wall. Shoulder blades touching the wall, standing nice and tall, and you're going to slowly bring your arms up. Try to go up as high as you can. Hold it for a couple seconds, and then slowly go back down to that starting position. So I'll have you do that real quick for me. Perfect. All right, so now moving into our second impairment that we talked about. We chose balance and coordination deficits because this would be a really common impairment you would see with patients with Chiari malformations. So for the max protection phase, we chose as our intervention, we chose that we would instruct the patient to do specific breathing exercises. We also said that we would have the patient do some seated balance exercises. And then depending on how they perform with that, we could have them do some standing but supported balance exercises. And so for this, the breathing exercises help enhance the postural stability. And then the seated balance exercises would offer a safe foundation for the patient to be able to practice and improve their balance, specifically leading into the progression to where you would do the standing but supported. So what I'll do for this, Lexi, I'm going to have you come sit down one more time for me right here. So for the breathing exercises, we chose to do diaphragmatic breathing. So, sorry. So for this, I'm going to have the patient take a deep breath. So inhale through their nose, and while they're doing this, they're going to try to expand their belly. Perfect. They hold it for just a second, and then we have them exhale slowly through their mouth. Perfect. And this could be a good exercise to have your patient do, especially in the max protection, because this is going to help increase the postural stability and their core stability. And then for our seated balance exercises, what I would have her do, we specifically chose some dynamic seated balance exercises. However, what I would want to do first with my patient is just ensure that when I get them in the clinic, they're able to sit upright without any issues. So obviously I know Lexi can do that. So what I would instruct her next, we would do seated marches. So while she's sitting, and she wouldn't be utilizing the back of the chair too much, ideally. So have you scoot forward just a little bit. Perfect. You're just gonna do some nice and slow marches. Perfect. We could have the patient do that for around 30 seconds to a minute and do around 3 sets. Another one that we could do could be seated weight shifts. And so essentially while she's seating and she is not leaning back on the back of the chair, she would just slowly shift her weight around. Perfect. And once again, this could be another one that we have the patient do for around 30 seconds to a minute and do 3 sets of these.
So to piggyback off of the balance and coordination deficits that we're doing our interventions about, the next one will be standing with minimal assist and also dynamic coordination exercises. So our explanation was because gradual progression to unsupported standing and coordination tasks will help retrain motor control and postural adjustments. Then after that, for the min protection phase, it will be balance on uneven surfaces and dual task coordination exercises, because our explanation was advanced balance and multitasking, improved neuromuscular integration. And then jumping down to the decreased muscle strength, which was our third problem that we wanted to address. For the max protection phase was isometric neck and upper body exercises, as well as scapular mobilization exercises, because isometric exercises prevent atrophy without excessive stress, and then scapular mobilization can help restore muscle activation. And then resistance bands for upper and lower body and functional strength exercises was for the mod protection phase, because resistance band and functional strengthening exercises both help to improve strength and prepare the patient to transition to daily tasks. And the last one that we wanted to do was progressive strength training and functional tasks to prepare for return to work sports. And the strength training will help to build endurance, and functional tasks will help implement similar performances of what will be expected of them when they return to work or sports. So for our exercises, we want to do standing with minimal assist. So for this one, I would have my patient to stand feet together or in tandem stance while reducing their hand support. So the muscles that we would be targeting would be the gluteus medius for the hip stability, the quadriceps for knee stability, and the tibialis anterior for ankle dorsiflexion. So, like I said, I'm going to just get this chair, since we don't have like any parallel bars or anything like that, and then I'm going to stand for a section. So we're going to stand in tandem stance, or you can do feet together. We're going to do tandem stance, and you're going to stand with minimum support, so just rely on the chair ever so slightly, just for like reassurance. And try that. Okay, and as I said, the muscles that we're targeting would be the quadriceps, like for hip stability, the tibialis anterior, as well as other muscles that I mentioned. And then for our dynamic coordination exercises, I would have my patient to do heel to toe walking and the tandem stance as well. Same feet placement, but I'm just going to alternate. You don't have to go such a long distance either, but just so we can just analyze it to make sure. Okay. For our minimum protection phase for the balance and coordination deficits, we would have them to balance on uneven surface, which would be like tandem stance on a foam pad or a host wall. So we're going to get this, I'll get this pad over here. Here, we're going to stand. And try to balance. So the muscles that we would be targeting here would be like our ankle stabilizers, like our perineals and our tibialis anterior hand for the foot balance. It would also be the gluteus medius for hip control and the rectus spinae for postural alignment. Alright. Oops. Now for our decreased muscle strength portion, for the max retention phase, we would do some isometric neck exercises because we'll be pressing the head gently against the hand. It's kind of like a rhythmic stabilization technique to just apply that small resistance without them having to do too much movement. And the muscles will be the sternocleidomastoid, our deep cervical flexors like we previously mentioned for like our chin tucks, and then the upper trap for postural. So I would have my patient to sit in the chair for this one. And then just for my own like personal comfort, I would just stand behind them and then I would instruct them like, okay, I'm going to be placing my hand over your head in multiple directions, and then you're just going to apply some resistance into my hand, whichever side that you feel my force. Just connect here. Like I said, this is also like a rhythmic stabilization technique as well, just for that isometric contractions. Some might do this for like 30 seconds or 15 seconds. It's really just so you can just see and make sure that they're having the proper response to, well, your physical touch. Another one that we would do would be the scapular mobilization exercises, which would be like the shoulder blade squeeze, like for retracting the scapula. And the muscles we would be strengthening would be the rhomboids concentrically, as Dr. Carter previously mentioned. So I would have my patients use a chair or something. I would have them to sit, short sit. And I'm going to come behind them just so I can like gauge where I would want them to be contracting. So what I want you to do is I want you to retract your shoulder blades, but without lifting your shoulders. You don't want like this. You want just straight back, nice and controlled. Squeeze. Okay. I'm just gonna place my fingers here just so they can understand like where I want them to try to squeeze in. Alright, so we see that the rhomboids would be contracting in this position. Alright, and you can release and just hold it for a couple seconds. Alright, release.
How are they contracting? How are they contracting?
For increased muscle strength, we would do resistance band exercises where you would have like seated rows with resistance, like for the upper back, or you could do something like standing hip abduction using a resistance band. Yes, resistance band, like I needed one. Alright, so I would have you take a seat. And ideally, when I think of a So I just like this because I'm trying to use what we got. So you're gonna be seated doing this, but ideally you're going to try to do what I just performed.
It's an upper body row,
Yes.
upright row.
Hmm. What'd you say?
Question mark.
Well, yes, that's all. I could be wrong.
I don't know, I'm just asking.
Oh,
You mean the upper body row or
Yeah, upper
upright
body.
row? You mean upper body?
all right. Right, and then another one that we could do would be like a simple closed chain, for the simple closed chain exercise for our functional strengthening would be like wall push-ups, like for also control upper body strengthening, or partial sit to stand from the chair with controlled descent, but I would like to do the wall push-ups. So, I'm going to have my patients come over here. So, it's a nice, good distance away, like arm length distance away from the wall, not too far, not too close. Just gonna have a slow descent. Almost like you want your forehead to touch the wall. You're just squeezing that, you're just squeezing those scapulas together. And I may not have the best form when it comes to a wall push-up, because I don't like push-ups myself. But I'm happy to do that as well. Alright, and if you feel like any like stability issues, of course you could scoot your feet up a little bit closer just for like some modifications. But you could do about maybe 10, 3 sets of 10, just depends on somebody's tolerance or how fit that person is. Okay, so that's good. And then our last set of exercises, like for our progressive strength training and functional tasks to return to work, we would have, you could do like an overhead dumbbell shoulder press, or a weighted squat or step up, but we're gonna do the overhead dumbbell shoulder press. So, ideally, you would identify, make sure the patient will be able to lift the weights that you give them, but since I know Jordan can do this, give you these two 10-pound weights, and we're just gonna mirror what I'm going to do. So, you just press overhead with the dumbbells, nice and controlled, and bring it right back down. Once again, press. Okay. Ideally, you would do, again, just like the wall push-ups, you could do like 3 sets of 10. It's just showing the moderation per patient. So the muscles that you would be targeting here would be like your deltoid, your rotator cuff for like shoulder strengthening. And you could also be targeting your erector spinae and multifidus for like the spinal stability, because if I had my patients in a chair, then they would have to have like good posture in order to be able to control the weight up and down. And then for functional tasks, we could do carrying like objects while walking, or pushing and pulling movements like mimicking daily activities such as like dragging a suitcase or lifting something from a shelf, or like some sport specific or work specific drills like reaching, throwing, or lifting like heavy loads. So for this one, just for, you know, ideal purposes, I would have my patient to utilize something over here. Well, height purposes, Jordan's fairly tall compared to what I would have to do, but if there was like an imaginary shelf, I would just have them to reach up, just nice and controlled, grab something, back down, reach up again, and they would just be repeating that motion back to back. Now this is just for visual purposes because I know Jordan could do it, but if it were anything that needed to be modified, like a shelf or anything, or something, or another task, then I would need it too. But the muscles that would be targeted for this one could be like, well, core muscles, you could be targeting your rectus abdominis or the transverse abdominis, like for trunk stability as you're reaching up, or you It could also be if they were lifting something from off the ground, then that would be like your hip flexors and your extensors. They would have to reach down and pick something up, like in a nice controlled fashion.
Right. And these are our references that we use. And are there any questions? Kiki?
I was just wondering, I was trying to picture it, how do the snow angels work on cervical range of motion?
So the snow angels, they are more so targeting the shoulder range of motion and the shoulder muscles. But we know that a lot of the time when a patient has cervical issues, they're going to overcompensate with their shoulder muscles, so it's just targeting that as well. Any other questions? Here.
What are some other breathing exercises we can do?
So the one breathing exercise we did was the diaphragmatic breathing. I believe that that's personally the best one to really target the posture. However, we could have the patient do a form of breathing that is sometimes just called controlled breathing, where you're just gonna have them take a deep breath in, hold it for say 5 to 10 seconds, and then slowly breathe out. And that one can just help with overall respiration, but it can also help relax the patient during treatment. But like I said, the one that I think is best for posture would be the diaphragmatic breathing. So that's really targeting the core and the trunk muscles.
Because this condition is like so, it can be severe and it has so many different stages. What precautions do you think you should watch out for when prescribing these interventions?
Yeah, so for Chiari malformations, I would say a good rule of thumb for any of the types would be you want to make sure you're not having the patient in too much cervical stress or cervical strain. You also, throughout treatment, just want to make sure that you're not worsening any of the symptoms and that the patient's not becoming dizzy or anything, especially when we're working on the balance and coordination aspect of it. Are there any other questions?
So I have a comment. So with this condition, this is a condition that I would incorporate. So I have a spectrum of approaches that I use when I'm in the clinic. One is the McKenzie approach. So I utilize the McKenzie approach heavily with certain conditions or with certain diagnoses or impairments that the person may have. But in this case, this is one where before I implement a plan of care, I would implement repeated movements. I would perform repeated movements. I would see which movements exacerbate and reproduce the patient's symptoms, because they have malformations, right? And so since they have malformations, one movement may be excruciating, painful, and reproduce signs and symptoms more so than another movement. So it's going to be very important to identify those movements that could exacerbate the pain, reproduce symptoms, that could reproduce ridiculous symptoms, and it'll be good to identify the movements that reduce the signs and symptoms that a person may be having. And then you use that data to implement a plan of care as well, okay? So that's good. So with McKenzie, if you learn McKenzie, we may go a little bit into it in this course, but you have postural derangement, you have discogenic disarrangement of both of this, and then you have mechanical problems. So the goal is to find out which classification that the patient goes in. Now, with Chiari malformation, it could be a complex case because this person can fall into all three categories. They can fall into postural dysfunction. You have to address posture. They could have derangement going on with maybe nerves getting compressed, and then they can also have mechanical problems. So this could be what you call a complex patient, you know, and a patient that will have high complexity. So if you have low complexity, moderate complexity, high complexity. And when you complete your documentation, you know, in your whatever source you use to document, this would be somebody who would probably be high complexity. So you just have to be cautious in your approach. So you all did a good job, but this is gonna be somebody, and this just gives us a foundation, gives us an idea of where you can go in the clinic. But this is gonna be a patient who's not cookie cutter. So this is something that, like sometimes in the classroom, is not a straightforward intervention that a professor can teach you to do for a specific case. Because now you're gonna be in the clinic and you're gonna use your knowledge and skills to drive your clinical decision making. But in the classroom, we're just giving you a foundation and giving you a way to think about it, a way that you can potentially approach it, you know. But, good job. Excellent job.
Thank you.